testing, what labs do you think they would draw?
ABGs.
ABGs? Fed rate?
Electrolytes.
Electrolytes, like a BMP, like a basic metabolic panel. Okay, because I want to know what my sodium, my potassium, my chloride are. Okay. What else would I want to know? Glucose, definitely. All right, because remember I said that elevated glucose, especially those with diabetics, impedes healing in these patients. Typically, we have a worse outcome if that blood sugar is not regulated. The other thing I want to think about is like CDC with differential, because I definitely want to know what my H and H are. Okay? Because if I have had an injury somewhere other than my head, I may have lost a lot of blood. One of the things that I will tell you is that if you have a patient with a hypertensive blood pressure and you think it's due to blood loss, it's not their head, it's somewhere else. The exception to that will be your infant, okay? Because if they are bleeding in their head, most adults can only accommodate 50 to 100 cc's of blood in their head without having intense intracranial pressure signs, okay? Now, if you get a scalp wound, those things bleed like stink. Because why? Okay, but what's different in the capillary beds or the blood vessels in the scalp than in anywhere else in the body? They have clotting factors, but they do not have the ability to vasoconstrict. Okay, that's why scalp wounds bleed like crazy. You have to hold pressure on them forever. Now, kiddos, infants, up into the age of, say, 2, 3, basically can lose enough blood from a scalp wound to be hypotensive. Infants can have a tremendous amount of bleeding in their head compared to the blood volume that they've got in the rest of their body. And they may be hypotensive because of that blood loss. But you get someone 8 years old and up, look for another source of blood loss other than their head. So I definitely want to know what my H and H is because I already know that I need that hematocrit to be adequate to carry oxygen. And if I've got a low hematocrit hemoglobin, it's going to contribute to an oxic brain because I don't have enough red blood cells to carry oxygen to the brain. Now, cerebral blood flow typically is not done until that patient is sort of stable because it's an ultrasound test to see what their blood flow is through their carotids up into their vasculature. One of the things that you will see is that they can do a guesstimate, a DUA, or CTA. A CT scan with a component like an angiogram. An MRI with a component like another angiogram. Okay? Those are much, much better pictures of blood flow to the brain than actually doing an angiogram or ultrasound. Because you can see what the vessels in the brain actually look like. And believe me, they're a whole lot safer and a whole lot quicker than trying to do ultrasound or angiogram. Now, gold standard for a head injury is still CT. It's quick. And there's not a lot of contraindications. Because you got someone comatose laid out in your ER, you don't have time to ask them, do you have a pacemaker? Do you have a metal implant anywhere? Are you a welder? Why is welding important?
Or you think of getting metal in their nose or their eyes.
And it turns into tiny little Cuisinarts. There have been ever reported cases of blinding for people that get their chop because of metal fragments in their eye. But MRI usually is one of the tests that we will use later on to see what more specific damage is done. CT is a screening test. What we're looking for is blood or damage. MRI will get us a much better picture of what that damage will be. Okay? But often you will see MRIs done after that patient's stabilized. Now, this is a KDOD. Cerebral perfusion pressure is equal to the MAP versus minus the ICP. So how do I calculate the MAP, or mean arterial pressure? What's the easy way? Just look at the computer. Push the button on the machine and it says MAP. Okay. Basically, you don't have that because some instructors don't give you that. And they make you figure it out because this is math. The mean arterial pressure is equal to the systolic blood pressure plus 2 times the diastolic divided by 3. Okay? So think of mean arterial pressure as what the average of those 3 numbers are. It will give you an indication of how much blood flow is getting to the cerebral vessels. Remember I told you that autoregulation basically works if the MAP stays in the normal range. Well, what happens is that for the cerebral vessels to perfuse, we like that mean arterial pressure to be at least 70. It will still perfuse somewhat at 60, but below 60, that patient's going to be out. DFO. That's why when you stand up real quick, you feel dizzy, your mean arterial pressure is not able to get that blood up. So, mean arterial pressure, let's just work one. We got a blood pressure of 120 over 70. What's my mean arterial pressure?
Say that again.
167.
I didn't hear what the BP was. I didn't hear what the BP was.
120 over 70.
120 over 70.
I got 162.66.
I got 86 or 87 or so. Okay. Now, is that adequate to supply my brain?
Yes.
Okay. Now, let's do a 110 over 60. So that's still adequate. Okay. But what you will see is that if I have a patient that goes much below that, under 100, I'm going to have a patient that's not going to have an MAP that's going to be adequate enough to supply my brain, especially if I've got someone with an elevated ICP. Okay? Because remember, what's happening is cerebral perfusion pressure equals the MAP minus the ICP. Okay? So, if I get a patient that has an MAP of 60, and my ICP is 20, cerebral perfusion pressure is not adequate to get that blood up in the head. Okay? So what happens is that as your ICP rises and stays elevated, you're going to have to maintain that pressure a little higher to overcome that resistance that it's going to meet as it tries to enter the brain. Okay? So it's very, very important that you know what that patient's MAP is. Well, say for example, I don't have an interventricular catheter in them to maintain their ICP, to see what it is. Just use 15, that's your upper level, and see if it's still adequate. Now, if they're starting to be a little squirrely, and that's the way they usually are, they're irritated and restless when they first start having problems with elevated ICP. Then you can bump that number up to maybe 20 and see if their perfusion is adequate. Okay? So it makes a difference. Yeah, what is that blood pressure? But I want to know what their MAP is so that I'll know, are they getting enough blood to the brain? Now, you'll find that I like these. These are nursing made ridiculously easy or something insanely easy, or I don't know what it is. It's something easy. But what they do is they put all of the stuff you need to know on one slide. So let's look at some of the increase in intracranial pressure signs. Changes in level of consciousness. Headache. Okay? And it just feels like pressure. Now, when is the headache going to be worse? Actually, it's better lying down. It's whenever you stand up. Okay? Because it's just one of those physics principles that whenever you lie down, your ICP basically equivalates between your head and your spine. Okay? But when you sit that little basketball up on the top of your head, there's downward pressure. So the pressure is going to be a little bit higher whenever you first get up. Okay? Usually it's worse than once. Now, with eyes, you see papilledema. Well, you don't know that unless you can use an otoscope. But what I can see as the nurse at the bedside is pupillary changes. My pupils are getting larger, progressively larger, and slower to react. The other thing is I can look at extraocular movements. You know, where you do that thing, let's follow my finger, don't turn your head, no, don't turn your head, look here, look here, look here, look here, and then back and forth, okay? Those are the extraocular movements. The easy way to remember them is this little mnemonic. 4 noses, 6 ears, everything else say 3. So, cranial nerve 4 moves the eye in towards the nose. Cranial nerve 6 moves it out towards the ear. Every other way is 3. Easiest way to remember it. 4 noses, 6 ears, everything else say 3. Now, why are they doing that back and forth? What are they looking for?
Are they moving together?
Are they moving together? Do they have a conjugate gaze? Okay. What else are they looking for?
Shaking.
Shaking, or what's that shaking called? Nystagmus. Okay. That's what, when the cop does that at every roadside check, alcohol will cause a lateral nystagmus, and that's what they're looking for. So if you've got a lateral nystagmus, you better have your doctor's note, or else you're going to be out doing this work. Walking the line. Okay? Conjugate means moves together. Okay? Posturing, the cerebrocortical flaccid. Changes in speech, verbal, confused, or can they have aphasia, meaning that they're having problems either understanding or speaking? You may see seizures in late stages. Remember that Cushing's triad we talked about? Vomiting. And we're talking projectile vomiting. And I thought all vomiting was projectile until I saw projectile vomiting from ICP. We're talking Raven from The Exorcist. I mean, do not stand at the foot of the bed. You stand to the side. Because that vomiting is, you don't need a little emesis basin. You don't need a bath basin. You need a tub. Okay? Vomiting. And typically this vomiting is without nausea. It's just all of a sudden, and it comes flying. Now with infants, some of the other things that we see is that increased head circumference. That's one of the reasons they check that, is to look to see if they're developing a hydrocephalus. You may also see cranial suture separation and bulging fontanelles. Okay? Instead of sunken, they sort of pop up, and you can palpate. And actually, to tell you the truth, if there's enough ICP elevation, you will see pulsation because the brain will be pushing against that fontanelle. And you'll see the blood vessels, the arteries in the brain pulsing. You may hear a high-pitched cry. It's called cri de chat. It sounds like a cat's cry. Very high-pitched, very, very abnormal type cry. And those are the symptoms that you see in infants. What is it called?
Cri de chat.
C-R-I-E-D-U-C-H-A-T-T. It's the cry of the cat.
It's 3 words.
But it's just high pitched. It's like chalk on the fingernail on chalkboard is like that. Some of your other assessments: headache, seizures, Cushing's triad. The other thing we'll see is CSF leakage. If you have a patient that has had a head injury, and specifically what we call a basilar skull fracture, okay? It's a fracture of the base of the skull. In other words, if you cut my head into here and lifted it up, the base of my skull has some type of fracture in it. It's very difficult to see on x-ray. But CSF leak is one of the things that you'll see, either from the nose, from the ears. I've even seen it from the eyes. Yes. One of the cardinal signs for a basilar skull fracture or a basilar skull fracture is CSF leak. And we'll talk a little bit more about that when we talk about skull fracture. But one of the things you need to remember, if this is leaking out, what can get in? Bacteria. So this patient is at risk for infection. Now, how can I tell if it's CSF or just regular snot whenever it's coming out of their nose? How do you test it?
Glucose.
Glucose, unless there's blood in it, okay? Basically, one of the things that you'll see is that if in the CSF, since it's a filtrate of blood, the glucose level of that CSF should be about 60% of what their normal blood sugar is. Okay? So, for example, if you had a patient with blood sugar of 200, 60% of 200 would be whatever. I don't do math in my head. And that would be, you could actually do a glucometer check and it would come out like that. Okay? Now, if it's got blood in it, that invalidates the test because blood has glucose in it. What I would do if I had a drainage, collect some in a little cup or tube or something, and then I would just, if it had blood in it, just pour it on a pillow. Typically what you would see is that the blood cells will clump and the CSF will make a halo around those blood cells, sort of a yellowish halo, and that's what that halo sign is. Okay? But anything that's leaking or draining from the nose or the ears or the eyes, that healthcare provider needs to know about to rule out that bacillus blood pressure. Okay? Now, increased intracranial pressure, we talked about some of this. Again, it's different than shock. What you see with ICP is elevated blood pressure, lowered pulse, lowered respiration. This is called Cushing's triad. And Dr. Cushing was the father of neurosurgery. There used to be a picture of him on our news. He was old as the hills, but he still practiced medicine. All right, shock, you see the opposite. Low blood pressure, high pulse, high respirations. So this is not a shock state, but it is a state that will cause death if untreated. Typically, if you're starting to see this Cushing's triad, you got 30 minutes until either death or permanent damage occurs. But we want to catch it before it gets to this point. Unless you're like my poor patient, you just sit there and watch. Yes. Now, with increased intracranial pressure, what we want is to prevent or detect it. Well, how do you prevent or detect it? People just know they got something going on with their head, they're going to have it. A couple of things that you're going to see done is that typically our patients are either head to bed up 30 degrees or they're flat. And a lot of times it's based on physician preference. I've read a lot of studies, but the majority of them show that the head of the bed up 30 degrees will help with cerebral blood flow. But that's if that person is in a midline position with their neck straight. You got somebody slumped over like this, what's happening here? They got good blood flow, but what about here? Not so good. So typically we keep head midline. Head the bed up 30 degrees. Okay? The other thing that will elevate ICP is anything that elevates the intrathoracic pressure. Okay? So if I'm lying in the bed and the nurse has basically positioned me so that I'm on my side, pressure on my abdomen, okay? So the legs need to be straight. Anything that puts pressure on the abdomen, anything that increases that intrathoracic pressure is going to elevate ICP. And it's because of this. The veins in the brain drain by gravity. Okay? The veins in the brain drain by gravity. They are the only veins in the body that do not have valves. Because what do valves do? They prevent backward flow, right? Well, there ain't nowhere for backwards to go whenever you're at the high point. So they drain by gravity into that venous sinus, and then from the venous sinus, they go into the jugular back to the heart. So anytime you increase the thoracic pressure, you're going to decrease the amount of blood that can get back to the heart. So what are some things that would elevate thoracic pressure? Coughing, sneezing,
Bearing down.
bearing down to have what?
Baby bowel movement.
Valsalva maneuver typically is contraindicated for these patients. I have given more colates in my lifetime to patients with head injuries that if I ever find out it's carcinogenic, I'm probably the #1 cause of cancer in the Southeast. Okay? We do not want these people to strain to have demons, because what it does is it elevates their ICP. Okay? Don't want them to strain to do anything. When I turn these patients, what do normal patients do whenever you turn them? They hold their breath, right? No. What I tell my patients to do, take a deep breath, blow it out. Take a deep breath, blow it out. And on that blow, 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 I'm turning them. Because I don't want their intrathoracic pressure to elevate. Okay? What else would elevate your intrathoracic pressure? That often is unavoidable. Breathing. Hiccups. Hiccups. You can give me Thorazine for that. It'll go away. But think about my person with that GCS of 8. I have to put them on a what? Mechanical ventilator. Okay? And often what you will see is because most ventilators are positive pressure, I'm blowing air into their lungs. So it elevates their thoracic pressure. So you have to watch their ICP when they're on a ventilator to see what it does. So you may have to decrease their tidal volume, or the amount of air that goes in, until it's just adequate, because you don't want to overinflate this one, because it elevates their intrathoracic, which is in turn going to elevate their ICP. Now, let's talk about some nursing care. What do we typically do in your routine? Say, for example, those of you that work care partners, you go into the room in the morning, what do? Vital signs, turn, position, and do bath, get it all knocked out, and go. You cannot do that with your patients that have problems with ICP. Because every action that you do will elevate their ICP and keep it up, and then elevate it some more, and then elevate it some more. And it does not come back to baseline. You cannot stack or cluster care for these patients. Typically, you would do one thing, back off, let them come back down to normal. Do another thing, back off, let them come back down to normal. Yeah, it takes forever. But it's better for that person's brain. Now, let's think about visitors or nurses, are people that come into their room.
Stress.
Stress. Think about watching Jerry Springer. Because I'm going to tell you, a lot of the families you work with, you would think that they were guest stars on Jerry and Maury, and I mean, to the point that sometimes I have to do visiting hours for the wife in the morning, and when she goes to work, the mistress comes in. You don't want the two to meet, because anger and stress and all of those types of things will elevate ICP. Sometimes you do have to limit visitors, because if you see what their results are on that monitor, you have to tell them sometimes you need to be quiet. Sit here, hold their hand. Don't tell them that their grandma died and because she ran over the dog. She had a heart attack because she ran over the dog. You don't tell them stressful news like that, because their ICP is going to go up. Now let's talk about music. If I'm trying to lower someone's ICP, that it's been shown that music can do that. But what do I play? Classical. They're not playing classical for an AC/DC fan or Metallica, because what's going to happen is their ICP is going to go up. Know what kind of music they listen to. That's what's going to lower their ICP. Give someone that listens to classical Metallica, yeah, it's going to elevate your ICP. I think Michael Bublé is probably lowers everybody's, because you tune him out. But I love Michael Bublé, but still, it's one of those things that you need to think about what your patients are like. What are their usual experiences? My mom, whenever she went into the hospital after her heart attack, the nurses reported to me that, well, she's not sleeping. I said, turn the TV on. Well, we normally turn it off at night to decrease the stimulus. I said, my mother watches TV all night long when she wakes up, and it puts her right back to sleep. They turned on the TV and she slept for the first night. What is their usual routine? If they're used to that stimulus and they're not getting it, you might see an elevation. All right, let's finish this slide and then we'll get them out of here. Vital signs, Q1 to 2 hours or more often. With some of my patients, I'm doing Q15-minute vital signs. It's not so bad now when I've got automatic cuffs and stuff that will do it for me. But it used to be when I'm doing manual blood pressures, manual ICP readings, it was a little bit difficult. But your positioning of your cuff and your taking of your vital sign will depend on how severely injured the patient is. Hyperthermia is a no-no. What does fever do to the body?
Metabolism.
It raises blood pressure, but also what does it raise? ICP, because it raises what? Underlying metabolic rate. Okay? Anytime you have a fever, you're going to use oxygen and glucose more quickly. And the higher the fever, the higher the metabolic rate. So we want these people normothermic to slightly hypothermic. Okay? One of the ways that we are now using to preserve brain tissue is to put them on cooling blankets and lower their body temperature to like 93, 94. Because it saves brain, because it lowers your metabolic rate. And by doing that, you preserve brain tissue. We do it also with your patients after a heart attack. If they get spontaneous return of circulation on the way to the hospital. It's called a code cool or an Arctic cool or whatever you want to say. But hyperthermia is not something that these patients can tolerate very well. So we want to keep them normothermic to hypothermic. And cooling blankets or what other nursing measures you have to do to get them in that normothermia is what you need to do. All right, so this is where we will start tomorrow. And I will
ICP
finish
slide
this,
21.
and we will do the section